It's a great pleasure and honor to present at the 2020 CSRS virtual ICL meeting. My topic is complications associated with the use of BMP in cervical spine surgery. I have no commercial conflicts of interest to report. I do have intellectual property and shares in a separate corporate entity which have nothing to do with this presentation. I'd like to acknowledge Elias Eli, my spine fellow, who was very helpful in creating this presentation. Background. Bone morphogenetic proteins are polypeptides whose mechanism of action is osteoinduction of mesenchymal stem cells to induce and proliferate and differentiate into bone. Bone morphogenetic protein is widely utilized and enjoys a global market of $500 million. It is FDA approved for lumbar spinal fusion. However, in North America, it is off-label for use in the cervical spine. Again, to repeat, cervical spine utilization of BMP is off-label. It induces bone growth equivalent to or better than autograft, as supported by two papers, Landman in 2004 and Boeki in 2005. BMP is associated with complications: heterotopic bone formation, neck swelling, dysphagia, airway compromise, postoperative hematoma, bony end plate erosion, subsidence, wound problems, and seroma formation. Heterotopic ossification. Baskins in 2003 reported a randomized controlled study comparing BMP to iliac crest bone graft in 33 patients undergoing anterior cervical discectomy and fusion. There was solid fusion at 2 years in both groups. In fact, those patients treated with BMP had superior improvement in neck disability and in arm pain scores. However, there were 2 cases of heterotopic bone formation anterior to graft, possibly related to the use of BMP. And here you see an example of heterotopic bone formation anterior to the plate and in close proximity to the trachea and esophagus in this particular case. Arnold and colleagues in 2016 performed a sub-analysis of FDA IDE trial data where BMP2 was delivered on collagen sponge in a PEEK cage in 224 patients and compared with allograft used in 486 patients. At 2 years, heterotopic ossification was identified in nearly 80% of patients with BMP2 versus 60% in the allograft group. Heterotopic ossification was negatively associated with neck disability scores, neurological status, and overall success in the BMP2 patients, but not in the allograft group. Neck swelling and dysphagia. 3 studies to review here. Butterman and colleagues in 2006 reported a prospective study of 66 patients where iliac crest was compared with bone morphogenetic protein. In this study, 50% of patients with BMP had neck swelling versus 14% in the iliac crest group. Smucker and colleagues in 2006 performed a retrospective study of 69 patients, again, ACDF with or without BMP. In this study, 27.5% of patients had neck swelling when BMP was used versus only 3.6% in the non-BMP group. Vadia and colleagues in 2007 did a retrospective study of 46 patients with BMP and PEEK cages versus allograft, and they found significant swelling and dysphagia with BMP, as you see in this graph, with evidence for soft tissue swelling for the first 6 weeks after surgery before the swelling subsided and became comparable to the non-BMP patients. Cervical hematoma, perhaps one of the most feared complications after anterior cervical spine surgery. Shields and colleagues in 2006 reported a retrospective study of 151 patients where high-dose BMP2 was used. In this study, there was 35 patients with major complications due to hematoma formation in the cervical spine that resulted in either a need for surgical evacuation or readmission due to swallowing or breathing difficulties. 14 patients in the study were diagnosed with a hematoma postoperatively, and 11 patients had hematoma identified on postoperative day 4 or 5, of whom 8 were surgically evacuated. 13 patients in the study had a prolonged hospital stay greater than 48 hours or had hospital readmission because of swallowing or breathing difficulties. End plate erosion subsidence. Vadia, in a study of 2000 and published in 2007, did a prospective radiographic study of 23 anterior cervical discectomy infusion patients. Allograft with recombinant BMP was compared with allograft and demineralized bone matrix. 2-year follow-up was provided. Fusion was excellent in both groups. However, those patients treated with recombinant BMP2 showed early lucency and subsidence in 1 of 3 patients, where the mean subsidence was 53%, with end plate absorption reported in all cases. In 2008, the FDA issued a public health alert stating that BMP should not be used for anterior cervical spine surgery. And Urumchuk in 2010, in a retrospective study of 260 cases, found that BMP was associated with longer hospital stay, more charges, more tracheostomies, more unplanned intubation, readmissions, and mortality at 90 days, as shown in the above graph. Now switching gears to posterior cervical spine surgery. Here, more wound complications have been observed with the use of bone morphogenetic protein. Crawford and colleagues in 2009 performed a retrospective study of posterior cervical spine cases where BMP was compared to iliac crest bone graft, where there was a greater risk of wound complications, 14.7% with BMP versus 2.8% with iliac crest bone graft. Hugh and colleagues in 2011 performed a retrospective study of 204 patients who underwent posterior cervical fusion with or without BMP and showed no difference in the rate of infection, but found that BMP had higher rates of neck pain. Anderson and colleagues in 2011 described 2 cases where posterior cervical decompression and fusion with BMP resulted in neurological decline due to excess seroma formation causing cord compression at postoperative day 5 in one case and postoperative day 14 in another case. In 2010, a commercial recombinant BMP2 product with a higher concentration of BMP, 2 milligrams per cc, compared to 1.5 milligrams per cc, was rejected by the FDA due to a possible increased cancer risk in individuals undergoing posterior lateral lumbar fusion. In this study, a 3.8 rate of new malignancy was reported amongst the patients who had the higher dose compared to the lower dose, where the rate was 0.89% at 2 years. And at 60 months follow-up, the higher dose group was associated with a 5% rate of new malignancy versus a 1.8% risk for the control group. So in conclusion, bone morphogenetic protein is not FDA approved for use in the cervical spine. It is contraindicated for use in anterior cervical spine surgery, and higher dose BMP products may be associated with increased risk of cancer, and therefore the use of higher dose BMP products is discouraged. Thank you for the opportunity to present at the CSRS virtual ICL course.